Hi, this is Glenn Woodworth from the Anesthesia Toolbox and the Society for Education, and we've got a joint webinar today with a very special guest. This is Dr. Adam Szulewski, and I hope I pronounced that right. It's a little bit difficult to pronounce, but he's an MD, PhD emergency medicine physician and an expert in education research, and he's an education scholar at the Queen's University in Ontario. So fantastic guest today, and he is an expert in cognitive load, which has broad implications for not only how we practice medicine, but also how we teach. So I thought he'd be a great guy to interview for our faculty development podcast. And so I welcome and thanks so much for joining us.
Glenn, thanks for having me. I'm excited to be here.
All right. Well, why don't we just jump right into it? So maybe we should just start out with a little bit about what is cognitive load.
Yeah, so I think people often think about cognitive load in a few different ways. And I think in medicine, we've been using that term for a few years. But really what cognitive load is the amount of working memory resources that you're using at a given time. I like to think of it as how hard you have to think about something. That's kind of the short version of what cognitive load is.
Is it a little bit more complicated than our old concepts of the number of, the 7 plus or minus 2 things you could maintain in working memory?
Yeah, well, it's related to that. The working memory is thought to discrete pieces of information that people can manipulate in their brains. And what cognitive load is and what cognitive load theory does is it builds upon that. And originally, cognitive load theory was developed as a theory of education. And the idea is you want to be able to optimize people's limited working memory in order to improve educational delivery and design. And so essentially, it builds upon working memory as a concept and uses that to optimize the delivery of teaching.
Wow, that's interesting. I didn't realize that it was a theory that grew out of an education theory. I thought it was one more really of cognitive psychology and on memory. Well, that's great. Thanks for the background on that. Well, how did you become interested in this topic?
Yeah, well, primarily, I think it all came back to when I was a resident. I remember standing in the corner of a busy resuscitation with mentors and people who I looked up to as the staff physicians, trauma team leaders, for example, and being really amazed and impressed by how easy it all seemed to them. It was like they could make decisions. It didn't look like they were thinking very hard. They could do a number of different things simultaneously. So not just manage the trauma, but teach medical students and residents. They could bring family into the room. And while doing all that, they could still do an expert job at managing the trauma. Whereas when I started into that role as a junior and then more senior resident, I found myself so cognitively overloaded, for lack of a better term, during those times that I wasn't able to do all those other things that my mentors seemed to have an easy time with. And so I started thinking about cognitive load then. And then with Dan Howes, who's one of my mentors and a faculty member at Queen's, we started playing around with eye tracking glasses at the time. So he had purchased this set of eye tracking glasses that he had used in some experiments. And we did a little bit of reading about them, started reading some of Daniel Kahneman's work on dual process theory, and started to get interested in cognitive load and how physicians thought. And that kind of evolved into thinking about how medical students and residents think during crisis situations. And that took me into to a master's degree and then a PhD in cognitive load and health professions education. I guess that's a short version of the last 10 years.
Well, that's a great journey. I call it going down the rabbit hole like Alice. You get interested in one thing and you just keep going until to where it leads you. So it sounds like, though, that cognitive load is critical to decision making, just routine decision making, but clearly becomes more important as more things get loaded into that channel. So we'll come back and discuss that a little bit more. But maybe we can ask, well, how do you measure cognitive load?
Yeah, so there's a couple of different ways of measuring cognitive load. I like to think of it kind of divided into 3 separate categories. So the first method is really a psychometric surveying. So asking folks, how hard they were thinking, and it measures a perceived mental effort. And so it's essentially a survey, like one that you'd expect to see. The second way of measuring cognitive load is with physiological variables. So I mentioned eye tracking earlier. There are some eye tracking metrics you can look at. Pupillometry specifically, so the size of your pupil in real time. And I can give you an example of that in just a second. Heart rate variability and galvanic skin response are other ways to measure physiological markers of cognitive load. And then finally, what's called secondary task methodology. So for example, let's say you're running a resuscitation and I ask you to press a button every time I turn a red light on in the room. The more cognitively engaged, the more cognitively loaded you are in your primary task of running your resuscitation, for example, the longer it takes you to press the button when you see the light. So those are different ways of measuring cognitive load.
Well, now you've kind of scared me because you talked about the secondary task. You've got a primary task that you're focused on and have to accomplish, and my performance on the secondary task is an indicator of my cognitive load. Well, probably many people are familiar with the video that you watch where the kids are throwing a basketball, and your task is to just count the number of times that the kids exchange the basketball. And during that video, I can't remember who made it. It's super familiar, but during that video, a gorilla walks right through the whole scenario, and it's how many people actually notice that the gorilla even went by. There's some other things too, like the curtains change color or something like that. A lot of times what you're trying to do is have people actually do CPR at the same time they're trying to count. But those don't sound like terribly big cognitive load, just counting the basketball, but then people totally miss the secondary task. So now you've made me worried that my capacity and my cognitive load is not very high.
Well, I don't know about that, Glenn. I would bet that you do a pretty good job in your work, and it really comes down to experience and expertise, right? It's funny, people look at that gorilla video that you mentioned, and they get angry at themselves that they didn't see the gorilla walk by, because the second time you see the video, it's so obvious. But you know what? It's actually a good thing that they didn't see the gorilla walk by, because they were focused on their primary task, which is their role. That's what they were asked to do. And that's why, for example, in complicated resuscitations, if you've got a big team at a teaching hospital, you know this, right? I mean, your team leader is supposed to be as hands-off as possible, because as soon as you get your hands busy doing something, whether it's compressions during CPR or trying to intubate somebody, you'll lose all situational awareness, and that's normal.
Yeah, and that's certainly something that we teach in our crisis resource management. Particularly, it seems that when you're involved in a physical task, that somehow affects the cognitive load more than some other types of tasks. I'm not sure why. Do you have a comment on that?
It's a good thought. I think part of it is there's mental engagement and there's physical engagement, and both probably have additive effects. So that would be my best guess.
Okay, great. All right. So we've talked about how cognitive load can be measured. Maybe you have some other examples of, just to kind of cement this into our audience. And by the way, I have to thank you of being a great guest, is when you make the host not feel so bad about their mental capacity. So why don't you give us some stories or some examples? I'm sure you have many, even from real life practice, about cognitive load affecting real life task performance.
Yeah, it's a good question, Glenn. I like giving this example about congestive heart failure management that I'll get into in just a second. I just maybe wanted to make one note. We're talking about cognitive load in the practice of medicine now, and in my opinion, I think there's a blurred line between where cognitive load is in education and where cognitive load is applicable in real life medicine. That's where we're at right now in the literature, and it's an exciting time because I think we're drawing some parallels between those two fields. But to specifically go back to your question about cognitive load and performance and in medicine, think about how you approach congestive heart failure, for example, right? Versus how maybe you approached it when you were a medical student. I'll tell you, when I was a medical student, I remember memorizing, the different aspects of congestive heart failure, and I thought of it as, some pulmonary edema, with hypoxia, and maybe I needed to provide some oxygen to the patient. I knew something about positive pressure ventilation that helped. I knew about diuresis in general, but each of those aspects was a part of my working memory. And you talked about the idea of working memory being seven discrete components plus or minus 2. Very quickly, you start to fill those up. And now when you think about congestive heart failure, oftentimes experts or people with more experience will just think of CHF presentation and CHF management. And those are two discrete elements in their working memory. And they have approximately 5 others where they can do other things. So for example, see the patient next door, or think about the next case if you're an anesthesiologist to prep for that. So it's really the it's successful resource utilization, essentially, from a cognitive perspective, that you're able to get at with increased expertise, increased experience. And those are some real life examples of how cognitive load plays a real role in our day-to-day work.
I'd say in my old cognitive science days, we would call that experts were constructing schemas, and that the instantiation of those schemas would allow them to more efficiently manage a particular situation.
So I think that's precisely it. So it's schema creation and schema automation. And now we're thinking there's a bit more to it. So there's that, for sure, as people develop expertise, but there's also what I like to call improved information reduction as well. And so what I mean by that is, maybe I'll give you another example. We do cognitive load research in simulation at our shop. And what I see over and over is this idea of information reduction, and how experts or even more experienced residents are really able to take advantage of that when they're dealing with scenarios. And the perfect example is the scenario of a patient coming in hypotensive with abdominal pain, who ends up having a ruptured AAA. And it's not really a diagnostic dilemma at all. That's pretty much given to all of the candidates as they come into the scenario. But soon in the scenario, within about 30 seconds, we ask the nurse to give each candidate the ECG as part of the shock workup. And it's really fascinating to watch our more senior residents. They'll have a look at the ECG and they'll say, "Thanks very much for this," and they'll put it to the side. And the next thing they do is they ask for the vascular surgeon on the phone, because what the patient needs is a vascular surgeon. Whereas our more junior medical students and our more junior residents will take that ECG and they'll start to analyze it, because there's something in this ECG that's going to give them a clue about how they're going to manage this patient. And really, that's just an inefficiency in dealing with the numerous stimuli around you, right? So in a busy OR or in a busy resuscitation bay, there's lots of stuff going on, but 90% of it probably doesn't matter in the moment. And being able to turn off and on your attention is a marker of expertise. That's a fascinating thing.
Yeah, so just to kind of put that in a nutshell, that ability to prioritize and disregard other stimuli or other information is helping you manage your cognitive load.
That's exactly it. So even before stimuli get into your working memory, even before you need to manipulate the idea of whatever the stimulus is about, it doesn't even enter into your sensorium necessarily. I mean, it does in a way. You're aware that it's there, but then you quickly block it off. So it's appropriate deprioritization as well as appropriate prioritization.
Well, that's going to be a great segue into the next topic, because I think a lot of times we think we're just like little machine learning, and just by nature of experience that we will gain that skill. But I think that you've got some thoughts on how we can apply cognitive load theory to teaching. I think one, maybe just to help us manage our cognitive load, but I think there's more concepts, because we've talked about task performance in medicine, and now we're going to make that switch that you discussed, which is how does cognitive load affect teaching and learning? So maybe we can start there.
Yeah, absolutely. So I think cognitive load, in terms of teaching and learning, there's 2 ways to think about it. There's self-learning and self-study. And then, of course, there's the delivery of education and teaching, right? So maybe we'll talk about the first. So in terms of self-study, there's a lot written about this. But the idea, of course, is you don't want your learners, or if you're a learner, to be cognitively overloaded. You don't want to overdo it, of course, right? But on the flip side, sometimes if learning is too easy and not cognitively loading enough, you're actually not accomplishing anything at all. And the classic example people use is the idea of highlighting. So if you have a text, a few chapters that you have to read, I've certainly done this myself. In my previous life, I would highlight texts, and I start thinking about what I was going to do that evening, and then all of a sudden I was through a page and a half. I'd highlighted half of it, but I had accomplish nothing really, right? And we all do that. And I think for learning to be effective, it has to be effortful. And it has to suck to some degree. And so there are different ways of accomplishing that. So people talk about interleaving and spaced repetition, and reflection and explaining concepts to oneself and quizzing oneself. Those are all effective ways of learning. And really what you're doing there is you're cognitively loading yourself up to a point, not to the point of overload, but you're getting something out of it. Right, so that's the kind of individual self-study. That's how cognitive load, I think, is relevant there. But from a bigger perspective, for the listeners who are teachers of medicine and other topics, I mean, I think we have to be aware of cognitive load effects on learners. So there's some basic stuff. You know, again, you don't want to overload your learners. You want to make sure you understand who your audience is, because your teaching is going to change depending on who you're teaching, whether they're junior learners or more senior learners. Sometimes we get into this challenge of having a simulation, and because simulation time is so precious, we throw all these learners in there, you know, our ones, our fives, you know, the whole group, and we try to deliver an educational product. But the truth is, it's probably targeting somebody in the middle. So those who are more junior are really struggling and they're cognitively overloaded. Those who are more senior maybe aren't getting much out of it anymore because they've seen the particular simulation, you know, 10 times during their residency. So there are some practical challenges to delivering educational material, taking cognitive load into account. But there's some theories about how to do it effectively. There's Jeroen van Meerenborg, who is my PhD supervisor, came up with the idea of the 4-component instructional design model, where tasks are delivered to learners in a simple to complex and low to high fidelity means over the course of time. And that's a good way of utilizing cognitive load theory to not overwhelm the junior learners, but to still challenge those more senior learners as they become more experienced.
So I could think of that as a matrix. You said that the 2 dimensions of the matrix were, again, what describe those two dimensions again?
Yeah, so there's complexity, right? And then there's fidelity as well.
Okay, all right. So if I was designing a simulation, an instructional course, something like that, I could think about where my learners were in that matrix to trying to design the instructional information that they're going to interact with or is delivered according to that matrix.
Absolutely. So, I mean, being an anesthesiologist, I mean, if you think about intubation, for example, that's the perfect task to take as an example. It's a complicated task. There's lots of things to consider, lots of contingency planning, and lots of patient factors that you have to take into account. So one way to introduce such a huge topic to learners is to do initially a whole task to just show them a patient who is struggling to breathe. You know, they're failing to ventilate. You know, they're a COPD patient, and you take them through how they're going to intubate that patient from the beginning to the end. So you show them in general what the whole task looks like. And then you divide out certain subtasks, right? So one subtask might be, well, assessment of the airway, assessment of patient factors, you know, plan for intubation A, plan B, plan C. And then you can parse out each of those and start with a simple case, you know, make it become more complex. Maybe you have some temporal compression. Maybe the patient is more sick, for example. And as time goes on, they get better at all those things. And then you bring the whole task back together. And that's a way to make sure that you're not overloading folks, right? Because if you take a junior learner and you ask them to intubate a complex patient who's crashing, I mean, that's not going to go well, and it's not fair to the learner either.
Yeah, so I think good instructors probably just do that instinctively, but we should be more explicit about that in our instructional design about what is the thing that we are trying to teach? What is the overall complexity of that thing? Do we need to break it down so that the less complex components will fit better with our audience's cognitive load is something that we should be thinking about in our instructional design.
Absolutely. And a lot of, I mean, the truth is a lot of clinical teaching happens a bit ad hoc, you know, in the moment. And you have various faculty who have various interactions with residents and medical students. And so you don't always have this ability to have a longitudinal curriculum per se in the clinical environment. So I think it's really important to have a proper longitudinal curriculum that's based on cognitive load in the background, so that you can take advantage of the clinical encounters, because they're sporadic and unpredictable.
Well, I assume you've been testing this. I mean, or at least there's literature where people have tested the effects of cognitive load on learning. So if we didn't properly manage the instructional design, that we would have a poor outcome. Do you have any comments on a little bit of the literature in this area?
Yeah, I think that's. I think, Glenn, just like you said, I think that's almost a given at this point. There's a lot of literature out there that speaks to that. Another interesting concept that maybe we should talk about is the idea of fidelity. And there's a number of systematic reviews that have come out in the last few years that suggest that maybe fidelity isn't as important as maybe we thought it might be, and you may know some of this literature as well. But if you think about it from a cognitive load perspective, it all depends on where your learner sits on their learning trajectory, right? You certainly don't want to have high fidelity for a novice learner necessarily, right? You want to, like we were talking about, break down those tasks into subtasks, and that's where task trainers come in. But if you take an emergency physician or an anesthesiologist or whoever who's been working for 10, 15 years, and you put them back into the simulation lab and you get them to go through an OSCE, often what happens is those individuals will perform worse than you'd expect. And this is a form of the expertise reversal effect that we see. And the idea is that simulation lab, those task trainers, are simply not real enough for those individuals to show how good they are, essentially. They're fantastic clinicians. They can manage complicated patients, busy emergency departments, difficult airways in the OR, but you take them back into a sim lab, and because you're decreasing the fidelity again, they don't perform as well. And you'll find that some of the senior residents who are about to graduate, who've been learning with simulation throughout their careers, will outperform them. But that doesn't mean that the expert isn't the expert. It just means that the fidelity isn't right for that person at that time. So that's also something to think about.
Oh, that's really interesting about matching the fidelity. Because when you first started out that discussion, I was thinking more along the lines that low fidelity actually can be super high yield, even lower than being in the full simulation center, because an expert in a lot of ways is able to parse out a lot of the other things in the environment, so that, and to reduce their complexity and focus on the task, which is what you're doing with a partial task trainer or a lower fidelity sim. Is you've gotten rid of a lot of the extraneous things, the surgeon yelling in the room, the nurse coming in and asking you questions, and you're focused more on just the mechanics of the particular task. So for example, we're teaching residents how to manage local anesthetic systemic toxicity. And we can do that with a very low fidelity sim, just in an empty operating room suite, just chatting, and we don't have to have a simulator and a patient with vital signs. But we can get the point across, and that they can practice and actually gain something from that before they actually go to a full high fidelity sim.
That's absolutely the way to do it. You need to have that background in a low fidelity environment in order to then be effective in a high fidelity environment. And it comes back to that 4-component instructional design model that I was mentioning, where as long as you grade your complexity from simple to complex and low to high fidelity, then you're going to be effective with your education.
Now, this might be a silly question, and I think because it clearly affects on how the cognitive load theory on teaching on simulation, but I think that's probably because most people that aren't as familiar with it as you are conflate it with the task performance issue. So let's kind of break it down a little bit. How would you apply cognitive load theory to the normal things that instructors are doing? Doing a lecture, teaching on rounds, or running a PBLD session with the group. How would cognitive load theory apply, or what tips would you give us if we were doing one of those things to apply cognitive load theory to that?
Yeah, so it's an interesting question. There is a whole body of literature that discusses cognitive load theory in education. So thanks for making that distinction, Glenn. So to this point in our chat today, we've been talking a lot about the practice of medicine, sort of apprenticeship, workplace-based learning, and how cognitive load theory applies there. When you're talking about lectures or PBL sessions, we're now moving back into traditional education. The good news, to answer your question, is there's a ton in the literature about this. There's actually a review that the fathers of cognitive load theory, so John Sweller, Fred Pass, and Jeroen van Meerenboer, published in 2019 in Educational Psychology Review, that talks about a number of ways that cognitive load theory is applicable. So, I mean, just to name a couple of things. One, you do have to know who your audience is to make sure that you're pitching your teaching at the appropriate level, right? So that kind of goes without saying. But in terms of multimedia and in terms of lecture teaching, you want to make sure that you're not, well, one thing is the split attention effect. So you don't want to have your learners looking at a slide where you have a graphic on one side with some words and then, you know, some text on the other side with similar words that are slightly different. What happens, you put up that slide, people start reading your text. And if you're explaining the graphic, their attention is split between the two. They're sort of paying attention to what they're reading, sort of paying attention to what you're saying. And overall, it's just a mess and nobody gets anything out of it. And so there are some basic things that you can do, right? So don't put up the text and just put up your graphic and explain it. And that way you hold people's attention, right? You just have to realize that people's working memory is only so large. And in fact, it's quite small. I mean, we were all in medical school. I remember infectious disease lectures where each slide had 50 different bugs that caused, 12 different diseases. And that was one slide out of a slide deck of 96 slides. And that was an hour lecture. I mean, these are not effective ways to be teaching.
That's why you didn't go into infectious disease.
That's a prime reason right there. And I suspect it might be similar for you too. But there are better ways of teaching that, right? So talking about concepts and ensuring that people do their pre-reading before they come to a lecture like that, right? So if I had come into that lecture and I had known the 12 categories of diseases that this lecture was going to talk about, then I would have a frame already. And then I could fill in the blanks of my frame from the lecture, right? But you need buy-in both from your faculty member, but as well as from your students as well. And sometimes that's difficult to accomplish, but there's lots of theory suggesting how you would do it.
I think what we'll do is if after this webinar is over, if you send me a link to the article, I'll publish that along with the podcast so that people can refer to that article, because it sounds like a nice one to have in our portfolio in this discussion. So let's kind of get some take-home tips. So we'll start with the self-guided learning. So what are your take-home tips to manage your cognitive load to improve the efficiency of your self-guided learning?
Okay. So I think overall, you have to be in the right headspace for it, right? You can't be doing it when you're tired or when you're hungry. You have to optimize those factors, of course. Bottom line is self-learning needs to be effortful to be effective. And if it's not effortful, if you're finding that you're just flying through it, either you already know the material and you probably don't need to study it, but more likely what you're doing is maybe you're not putting in enough effort to quiz yourself. And so do some reflection and make sure that you're putting in the effort, and make sure that it's difficult enough to learn, right? It's like exercise, right? If you're, anyone can run 200 meters, but to run, 20 kilometers, you got to put in the effort. It's got to hurt. So there's that. So that's from a self-guided perspective.
I also always comment on it was interesting to me the way you said about not just effortful, but the self-reflection, the asking yourself questions, attempting to answer them, or working with a partner in a dyad where you're trying to explain a concept. I've always thought that was, from a cognitive psychology standpoint, that was encoding. So it wasn't so much the cognitive load, but it was helping me to organize the information to higher orders of thinking, and that helped me encode the information.
Yeah, Glenn, you're absolutely right. So encoding and cognitive load are related but slightly different topics, right? So what you're doing there is you're encoding, you're creating mental schemas, and then you're automating them. But in order to create the mental schemas, in order to automate them, you have to have enough cognitive resources available, right? So I think that's how those two concepts are related.
Okay. Well, that brings up the next point as we go back now to the teacher about takeaways for the teacher. And we talked about complexity and we talked about understanding fidelity. But maybe before we finish off, is there any comment about, or have people done work in helping experts develop schema to teach the schema or frames to their learners? In other words, how can you help them construct a good schema or a good frame so that they become efficient?
Yeah, well, I think, experienced teachers do that by having taught for many years and having seen how their students react to what they're teaching, right? And that's how teaching becomes an iterative process, right? You teach something, you find that it wasn't well received, or folks didn't learn, and so you alter that teaching. So part of it is being able to go through that process yourself as an educator, as a teacher. Otherwise, piloting parts of lectures to certain individuals might be useful as well. But unfortunately, I don't know if there's an overall piece of guidance that I can give there. I think that comes with time, and that just gets better with that iterative process.
But I think it's maybe a suggestion is at least to think about it, to have the instructor think about what is the overall framework or schema that I want to fit this in. For example, let's go back to your heart example and your congestive heart failure. As opposed to teaching a list of things to do, you need to give a diuretic, you need to do this, you need to do this, you need to do that. Instead, setting up a frame, let's talk about how we want to manage the preload for this heart. How do we want to manage the afterload? How do we want to manage the inotropy? And now within those, that would lead me to, oh, I need to decrease preload, or I need to decrease afterload. And that kind of sets up a frame. And so that would be my example of trying to get educators to think about what is the overall framework or conceptual framework that they want to teach into, that they want to build those details into, and it will help the learners hang those details on that frame and better remember them.
Yeah, I think what you're talking about there, Glenn, is just cognitive architecture, right? Mm-hmm. And so you're absolutely right. So when you've got a novice, oftentimes the way their cognitive architecture works is they've got, a node connected to another node, connected to another node of knowledge, and it's often linear. And connecting the first node to the last node is difficult because there's lots of steps in between. Whereas if you frame it, as you mentioned, with expertise, those nodes become much more complex. And node 1 now connects not only to node 2, but to node 4 and node 17. And it's essentially what you're doing is creating a bit of a framework for that natural progression to occur with time.
Yeah, and I think also what you mentioned was having a framework. Once you've internalized that framework, then you become more efficient at managing your cognitive load.
Mm-hmm. And another thing to think about is, are there ways to utilize cognitive load in tailoring learning, right? Because I mentioned right now, often what we do is, because simulation time is so valuable, is you get a bunch of residents or medical students into a room with various levels of prior knowledge. Wouldn't it be wonderful if you could, in real time, alter the difficulty of a simulation scenario based on output from someone's real-time cognitive load? So if you notice that someone is cognitively overloaded, perhaps you could decrease the difficulty of the simulation. And if you notice that they're bored and not cognitively loaded enough, maybe you could ramp up the difficulty of the scenario. So that's what we're looking into in our lab right now. And so stay tuned. Hopefully we'll have something in the next 5 to 10 years.
That sounds really interesting. Of course, when I'm in the booth back there, I'm just trying to make sure that I got the blood pressure right. To have to be able to dynamically adjust the simulation based on the performance of the individual is a very interesting concept. Well, before I let you go, since I have such a wonderful guest today, maybe we can just talk. The elephant in the room is COVID. And, we're not able to do, I don't know about you guys, but we're not able to do simulation now, which was a very large part of anesthesia training. And how are you how are you trying to get around it? What are you trying to do in this situation that we're in? How do you provide simulation?
Yeah, you know what? I wish I had an answer. It's just been really unfortunate. We, as I'm sure you and everybody across the continent and the world have been doing, we've canceled more sessions that I can even describe to you. It's been really difficult. I think I don't think there's a good solution around this. I mean, there are certain things that learners can do, right? So we have been having more Zoom teaching sessions than I can even tell you, right? So we're substituting a fantastic learning method in simulation for old school methods that are sometimes effective and sometimes not. And now we're not even doing it in person, we're doing it over a computer screen. So I think it's just the reality of the situation we're in.
I wonder if that means a couple of questions and come to my mind. Is one, is it'd be interesting to, because the impact of COVID could be a year on education, and that's a significant chunk of time. And it's interesting to see what effect on the learners, on their overall performance and competency at the end of their training was this gap or this shift in their education. How was it better or how was it worse in terms of their end product, what they finished with? The other thing, maybe this means that we need to do more. Maybe we need to have more game playing and computer simulations that we could roll out as another stopgap measure during this time period. Because probably with game type simulations, maybe we could. It's a lower fidelity, but maybe we could get at some of these things.
Yeah, that's true. But I think it's always going to depend on who your learner is. So, a low fidelity computer based game type system is going to be effective for your junior learners, I think. And some aspects might be more effective for your more senior learners. But as people develop more experience in the clinical world, if you don't have effective fidelity, I think that that might become a problem. But, we're all dealing with this the COVID situation in the best way we can. We're just hoping that there's going to be that vaccination that everyone keeps talking about, and then everything will go back to normal. We'll forget 2020 ever happened.
It did make me think of one thing in terms of your research, that in a game playing environment, you actually might be able to have some automated load balancing or changing of the difficulty of the scenario in a game. It might be able to do it automatically. So that might be an interesting avenue to try and study the matching of the load with the learner and seeing effects on outcomes.
Absolutely. And I think, just to go back to what I was mentioning before, we're going to be looking at physiological markers of cognitive load in the real world. In real simulation, and trying to adapt scenarios to that. But yeah, it would be a lot easier to do in a computer-based environment where there's fewer distractions, and it'd be easier to do from a study perspective.
Well, Adam, thank you so much for joining us today. It was an excellent discussion on cognitive load. I'm sure everyone will learn something from listening to this webinar, and we really appreciate you having you as a guest. So thank you so much.
Glenn, it was great. I appreciate the invitation.
All right, good luck to you.
Thanks.